Hello, everyone. Welcome again to our Roadside E&M Assistance Interactive CCM Activity Pit Stop webinar. My name is Ashley DeCoto, and I'm a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who will be helping out with the chat. This webinar is part 2 of our 2-part series on chronic care management, or CCM services. Yesterday, Leanne held the part 1 webinar, which provided a more comprehensive overview on CCM. Now, if you were unable to attend her session yesterday, that recording will be available within the next week or so in the training center of our website and on our YouTube channel. We will also have a recording of this session available also on the training center of our website, and Leanne will be adding a link for the training center to the chat. And it will be available out there on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel, and it will stay there as long as this information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download in case you'd like to have the presentation to follow along or to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. We'll check in with Leanne at the end of the presentation, time permitting, for any unanswered questions in the chat. We did have quite a few questions that were pre-submitted with registration, and I will be answering those that relate to chronic care management throughout the presentation today. Now, if we do not get to live chat questions, we will answer those in a follow-up email. All right, for our agenda. So we'll start off by doing a brief recap from Leanne's part 1 webinar yesterday, where she went into more detail on chronic care management, including patient eligibility, provider eligibility, the elements of CCM, and correct billing. Again, if you were not able to attend that one, we encourage you to review the recording from the training center on our website or on our YouTube channel once those become available. Next, we will do a review of the top denials and top rejections for chronic care management. Then the remainder of the webinar will be our interactive Q&A activity. Also, I wanted to mention that I have included some resources in the presentation, and I will be going out to show you at least one of those. And this may be a resource you saw yesterday if you attended part 1, but we really want to make sure that you know these are available, especially for our activity today. All right, let's start with a recap of Leanne's session from yesterday. So chronic care management, or CCM, is a monthly service that can be provided to patients with multiple, meaning at least 2 chronic conditions. CCM is a proactive approach rather than a reactive approach to the patient's care, which will hopefully reduce emergency room visits and result in fewer hospital stays. Next thing we have is patient consent. You must obtain a patient's verbal or written consent to receive CCM services. Your patient's consent must be documented in the medical record. So you want to make sure that they know about their out-of-pocket cost, as cost sharing does apply for chronic care management. You also want to make sure that patients understand that only one provider is able to provide these services, so they cannot receive it from each doctor that they see and should not provide consent to receive CCM services from anyone else. We had a pre-submitted question which asked, what happens when another provider bills for CCM codes? So only one provider, again, can bill for these services. So if another provider bills, the second claim to come in for chronic care management that month would deny. Patients should also be made aware that they are able to stop CCM services at any time, but the service would still last through the end of that calendar month. The next thing we have on our list here is the initiating visit. An initiating visit is required before CCM services can start for new patients and for patients you haven't seen within the past year. That initiating visit can be done during an E&M visit, an annual wellness visit, initial preventive physical exam, or an IPPE, or it can be done during the face-to-face visit for transitional care management, or TCM. Chronic care management must be discussed with the patient in order for that to count as the initiating visit. Next, a comprehensive care plan is required as part of your chronic care management services and must be done electronically so that your clinical staff will have access to that care plan. The plan must be patient-centered and will include all health issues, but with a focus on managing the patient's chronic conditions. You'll want to make sure the plan is available both within your practice and outside the practice for other providers that are involved in that patient's care. Also, make sure that you're providing the patient with a copy of the care plan. CCM does require 24/7 access to care, which gives patients the support that they need between visits. This means that the patient should have access to practitioners or clinical staff any time of day. And this might be, for example, communication by phone. It could be through secure messaging, email, or by using a patient portal. All right, next up, I'll share what our top denials have been at WPS for chronic care management and complex chronic care management. So the denials listed on this slide are for claims submitted March 1st through May 31st, 2026. And this is again for both CCM and complex CCM codes. So our top denial for chronic care management was payment already made for same or similar procedure. So this could happen when you bill both complex and non-complex CCM for the same patient in the same month. For example, if complex CCM is billed in a month with moderate to high medical decision-making, non-complex CCM cannot also be billed in that same month. This type of denial may also be due to another provider billing CCM during that month. To help you avoid these denials, this goes back to the patient consent, where you want to make sure to let the patient know that only one provider is able to provide these services. Next here, we have duplicate charges, which might happen if payment was already made to you for chronic care management for that patient on that date of service. Now, if you believe your claim denied duplicate in error, you can submit an appeal. But duplicate charges continue to be one of our top denials kind of across the board for E&M services. So you want to make sure that your billing system is not set up to auto resubmit for your Medicare claims. Next on our list is claims denied while the beneficiary is in a period of managed care. And this would happen when the patient is enrolled in a Medicare Advantage plan. So make sure to check eligibility, which you are able to do through our secure portal. And if the patient has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare, meaning WPS, does not process those claims. All right, the next one on our list of denials is not covered when performed by this provider. So if you attended Leanne's session yesterday, you saw a list of who's eligible to bill for chronic care management. And that list included MDs and DOs, non-physician practitioners, RHCs, FQHCs, and hospital outpatient departments. There are some providers that are not eligible to bill for CCM. Let's go out and take a look at where you can find that. So what you see here on my screen is the MLN booklet on chronic care management services, which is linked on the resource slide. And for those of you who have downloaded the presentation, that will be slide 10. I've also asked Leanne to place a link in the chat for those who have not downloaded the presentation and would like to follow along here. So what I want to show you here relating to our last denial, we'll find by scrolling down to our table of contents. And I'm going to click on this second item, which is CCM service practitioners. So here you see a list of practitioners that are able to bill for CCM. One thing I find kind of interesting right here is that each of these practitioner types has a hyperlink, which will actually take you to the section of the Code of Federal Regulations defining that particular practitioner type. But what I really want to point out in this section is this note here, which tells us that limited license practitioners are not able to bill for CCM. So if you have maybe a podiatrist or a chiropractor, for example, and bill for CCM, you would receive this type of denial. We will be taking a closer look at this resource a couple times during our Q&A activity, so feel free to keep this page open if you're following along. All right, let's head back to our presentation and on to our last top denial for CCM. So the last denial listed here, we also saw a high number of denials for the patient being enrolled in hospice. So for patients in hospice, all care related to that terminal hospice diagnosis is included. Those that are not related to the hospice diagnosis, you will want to bill with the appropriate modifier. When a patient is in hospice, your CCM claims billed without any modifier would deny. All right, here we have the top CCM rejections for that same time period, which again was March 1st through May 31st of this year. Our first rejection is claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice, which would provide you with a bit more information. This could be really any of the items required for that claim to fully process, such as the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that all required elements are included and resubmit your claim. Next is incomplete or invalid modifier. You might see this type of rejection if you report a modifier that is not applicable for CCM, such as maybe a surgery modifier or a bilateral modifier. Since those types of modifiers do not apply to CCM services, appending them could cause your claim to reject this way. So if you believe there is a modifier that would apply, you want to make sure it's a valid modifier to append for that CCM service. And if maybe you added an incorrect modifier by mistake, you would just correct and resubmit your claim. Our third rejection is for missing, incomplete, or invalid provider identifier. These rejections happen if you are missing or include inaccurate information to identify your provider or facility. This could include the rendering provider's ID number, which is your provider's NPI. It could be an invalid or missing tax ID number or your facility location. If your claim rejects for missing this information, or maybe the information submitted was invalid, you would fill in that missing information or correct any errors and resubmit your claim. All right, the fourth one here is treatment rendered in inappropriate or invalid place of service. So the place of service that you'll report on your claim for chronic care management will be the location where your practitioner would ordinarily provide face-to-face services. So if your practitioner typically provides face-to-face services in the office, you would use place of service 11 for chronic care management. What we have seen cause errors here is using a telehealth place of service 02 or 10. Even though CCM is not typically a face-to-face service, you would not use a telehealth place of service. That would cause this type of rejection. The last one on our list of rejections is clinic number missing or not entered accurately. For these, you want to make sure that you've included your clinic's NPI and that it is entered correctly. Now, if you omitted the NPI or maybe you keyed a digit incorrectly, you would just want to make the correction and resubmit your claim. All right, I've included this slide here as a reference to help summarize what I just talked about for your CCM denials and rejections. For your rejections, you'll fix the error and resubmit the claim. Remember that for rejections, the claim was not able to fully process, meaning a claim determination was not yet made and the claim does not have appeal rights. Those, again, must be corrected and resubmitted. Now, for denials, your next step will really depend on the type of denial you receive. Your remittance advice is really going to be your best source to determine what's next. It may indicate that you need to resubmit your claim, in which case you can correct the error and resubmit. In some cases, you may be able to correct a minor error through a clerical error reopening using our Secure Net Access portal. This might be a keying error for your place of service or your rendering provider's NPI, for example. And you may have denials that will require you to appeal if you disagree with the claim determination. Your remittance advice in those cases would include remark code MA01, which indicates that you have appeal rights. We did include a link in the last bullet on this slide, which has some information on how to appeal a claim, if maybe you're newer to that process. Okay. Now we're going to shift gears into our interactive Q&A activity. And we've designed this to be what we think is a fun way to test your knowledge. So we will be launching a poll for each question. Even if you aren't 100% sure on the correct answer, we'd love to still have you participate and give it your best shot. I will give you a moment to lock in your answers, and then I'll walk through the correct answer for each question. I do want to note, though, for those of you who have attended our Q&A activity webinars in the past, you might see a slight difference in what you see in the WebEx software today. Due to some technical issues we're having this week, you may need to click on an icon with a plus sign. It should be next to the chat icon towards the lower right of your screen, and it would say something like show apps if you hover over it. And then it would allow for you to click on Slido, which is the platform we will be using for the poll questions. Before I launch the first question, we did have some pre-submitted questions asking for resources. This slide has resources for our activity today, and Leanne has just placed these links in the chat in case you haven't downloaded the presentation. And you're welcome to have these open to help throughout our activity. The first resource listed here is one that I find particularly helpful, and this is that MLN I went out to earlier when we talked about the denial for provider types. So there's lots of information in there that will be helpful for this activity. Okay, let's get started. So for our first question, we're going to start out a little on the easier side. Which of these is the basic requirement for a patient to be eligible for CCM services? Is it A, 4 chronic conditions, B, 1 acute condition, C, 2 minor problems, or D, 2 chronic conditions? All right, the answer for this one is D, 2 chronic conditions. In order to be eligible to receive CCM services, the patient must have multiple, meaning at least 2 chronic conditions. So for our next question, which of the following are not examples of chronic conditions? And you can select all that apply from these options. Is it A, depression, B, sinus infection, C, diabetes, or D, a rash on the elbow? All right, looks like most of you have your answers in. The answer for this one is B and D. A sinus infection and a rash on the elbow are not really examples of chronic conditions. CMS defines a chronic condition in that MLN booklet we looked at earlier. And actually, let's go back out there and take another look. So for this one, I am going to scroll down a little bit to page 5. And I'm looking here under patient eligibility. This is where it tells us that a chronic condition is one that is expected to last at least 12 months or until the death of the patient, or one that places them at significant risk of death, acute exacerbation, decompensation, or functional decline. So for our question, we would not expect that a sinus infection or a rash on the elbow is typically going to last 12 months or put the patient at any type of significant risk. What I also wanted to point out here is something Leanne mentioned yesterday, which is this bulleted list here that CMS gives for examples of chronic conditions. And notice this list does include depression and diabetes, which were 2 of our answer options for that question. So we know CMS considers both of those to be chronic. But notice that these are just examples. There's not an all-inclusive list. If you're not sure if you have a chronic condition, look to your documentation. Does it make it clear that the condition will likely last 12 months or that the patient is at significant risk of death, decompensation, or functional decline? Your documentation will be your best source in determining if this requirement is met. And there may be times where clarification is needed from the practitioner when the documentation is not so clear. All right, let's get back to our next question. All right, so this question asks, how often may CCM services be billed? Is it A, every day that service is provided in a calendar month, B, weekly, C, once per calendar month, or D, every day? All right, this group is super fast at getting their votes in. Okay, so for this one, the answer is C, once per calendar month. So we're often asked what date of service should be used. CMS addresses this in an FAQ on chronic care management, which we have linked for you on the resource slide, and also in the chat links provided for you to use as reference during this activity. So in that FAQ, CMS tells us that CCM services should be reported at the end of the service period, meaning at the end of the month. And this is really for your benefit. If you choose to bill sooner than the end of the month, CMS expects that you continue to provide the services through the end of that calendar month. So using the last day in each month as your date of service allows you to account for all time spent on chronic care management, and probably most importantly, allows you to receive payment for all the work that was done in that calendar month. All right. For the next question, which place of service should be reported if the provider is in their office and the patient is in their home? Is it A, place of service 10 for telehealth provided in the patient's home? B, place of service 11 for office? C, place of service 12 for home? Or D, place of service 21 for inpatient hospital? All right, it looks like we're split down the middle a little bit on this one. So the answer for this one is B, place of service 11 for office. And CMS addresses this in that same FAQ I mentioned for our last question. And the FAQ tells us that the billing practitioner must report the place of service for the location where they would ordinarily provide face-to-face care. So in the case of chronic care management, the place of service in this situation would be 11 for office. We had a question about place of service asking, what place of service code is best to bill when you provide outpatient CCM for a resident in an assisted living community? Well, the place of service would be wherever the physician would normally provide face-to-face services. So it's not based on where the patient is located, rather it's based on where the practitioner typically provides face-to-face services. So if the practitioner usually provides those services in the office, you would use place of service 11. If they usually provide face-to-face services, let's say from a hospital-based outpatient department, you would use place of service 19 or 22. So we most often see place of service 11 used for chronic care management. All right. For the next one, let me get that question launched. So this question is, complex CCM may be reported the same month as prolonged E&M services. True or false? I'll give it just another minute. I still have a few trying to get their answers in. Okay, I can appreciate the not sure answers. Totally okay answer. So the answer to this one is false. So if we go back out to our MLN booklet on chronic care management, what I want to show you for this question is on page 8. And this has some information on concurrent billing. So the answer for this question, I'll highlight here in the 4th bullet. Maybe I will. There we go. And this says that you cannot report complex CCM and prolonged E&M services in the same month. I do encourage you to use this section on concurrent billing when in doubt, if you're wondering if CCM can be reported the same month as another service. And there's also some information on concurrent billing in that FAQ that I've mentioned. Before we move on to the next question, another part of this MLN booklet I want to point out is a chart down on page 10. Nope. There we go. So this chart has each of the codes listed for CCM and complex CCM, the staff type, meaning clinical staff or physician, and then the time thresholds. If you're following along, I encourage you to keep this chart up for some of our remaining questions. All right. Next, you would not report 99491 in the same month as which of the following? And you can select all that apply from these options. So we've got A, 99437, B, 99487, C, 99489, or D, G2211. I'm going to give just another moment on this one. I still have a few getting their answers in. Okay, I think the last answer there kind of threw a curveball in. So the answer to this one is B and C, 99487 and 99489, which are those complex CCM codes. 99491 is non-complex CCM for the first 30 minutes of your physician time. Let's talk a little bit about each of these codes that are listed as the answer choices and why you would or would not be able to report them the same month as 99491. You are able to report the first answer choice here, 99437, in addition to 99491 for each additional 30 minutes of physician time. You would not report answers B or C, 99487 or 99489 in the same month as 99491 because you would not report both non-complex and complex CCM in the same month. Now for the last code listed here, G2211 is an add-on complexity code for E&M services. And there is a CMS FAQ out there on G2211 that does tell us this code may be reported in the same month as care management services. We did a webinar on this code earlier this year, and the recording of that is available on our YouTube channel. So I encourage you to take a look at that if you're looking for more information on that code, and it does also include a link to the G2211 FAQ that has the answer there. We had a question regarding concurrent billing that I want to share, which asked about frequency, and it also asked why 99487, 99489, and 99484 cannot be billed together. So first, for frequency, if this question is asking how often these services may be billed together, it's once per calendar month, or how often they may be billed, I should say, once per calendar month. And we do encourage you to wait again until the end of the month. Now, if by frequency this meant how many of these will Medicare cover per month, you'll need to look at the medically unlikely edits, or MUEs, on the CMS website. MUEs provide information on the maximum units of service that are considered for coverage. Now, for the sake of time, I won't go into all the details of MUEs today, but we do have a couple of videos on our YouTube channel that do specifically cover medically unlikely edits. So feel free to check those out for some more in-depth information. Now, for the latter part of this question, which asked why 99487, 99489, and 99484 cannot be billed together, well, those first two codes are designed to be billed together. So 99487 is the first 60 minutes of complex CCM. 99489 is each additional 30 minutes, and you would bill that along with your 99487. You would not bill 99489 without 99487. For the last code that was mentioned in this question, which was 99484, this is a behavioral health code for care management. There are situations where a patient may be receiving both CCM and this care management for behavioral conditions, or 99484, but you aren't able to count your time twice. So your CCM codes can be billed the same month as 99484, as long as time is not counted for both and documentation supports that they're separate. So it should be clear which time is spent on behavioral health care management and which time is on chronic care management. All right. So next, CCM services are typically provided during face-to-face visits. True or false? All right, the answer to that is false. CCM services are not typically face-to-face services. It usually involves non-face-to-face services to provide support needed between visits. So it might include things like telephone communication, medication management, review of medical records or test results, sharing information with other practitioners, just to name a few examples. This does not mean that CCM services cannot be done face-to-face. Just keep in mind, though, that time counted towards CCM cannot be counted towards any other code. We had a pre-submitted question which asked for examples of calls that cannot be billed. So you would not count things that are administrative, such as a receptionist calling to reschedule an appointment or remind the patient of an upcoming appointment. You would not count any tasks completed by administrative or non-clinical staff, such as billers speaking with a patient about their bill. You would also not count time incorporated into another code. So for example, if you're gathering information from, let's say, an independent historian for a patient who has a visit today, you would not also count that time towards chronic care management if that time is being incorporated into the time for that evaluation and management service. You can't double count that time. All right, our next question. Nope, not that one. There we go. So our next question is, which of the following CCM services may be performed by clinical staff under the Incident to guidelines? And you can select all that apply from these options. Is it A, 99491, B, 99437, C, 99490, or D, 99439? I'm going to give it just another moment to give everyone a chance to double check on those codes. Okay, so hopefully some of you used the chart in the MLN booklet. The answer for this one is C and D. So you have 99490 for chronic care management by clinical staff for the first 20 minutes and 99439 for each additional 20 minutes. For this one, keep in mind that practitioner time may count towards clinical staff time, but it doesn't work the other way around. So for services done by your clinical staff under the Incident 2 guidelines, only those codes designated for clinical staff can be used. We had a pre-submitted question which asked, how does the provider stay within Incident 2 billing guidelines if the comprehensive care plan requires updates? That's a great question. So CCM Incident 2 guidelines require general supervision, meaning the services done under the billing practitioner's overall direction and control. The billing practitioner does not need to be physically present during the CCM service provided by clinical staff. But you want to make sure that the documentation shows the billing practitioner's continued involvement in that patient's care. So if there are changes to the billing practitioner's care plan, that billing practitioner needs to be involved in those changes, and the documentation must reflect their involvement. The CMS FAQ on chronic care management addresses the practitioner's continued involvement. The FAQ says that the billing practitioner must retain a certain level of involvement in CCM, including oversight, management, collaboration, and reassessment by the billing practitioner consistent with the included service elements. So how have they been continually involved in that patient's care? Maybe they reviewed the results of recent testing and increased a medication based on that review. Or maybe they reviewed labs and determined that the existing dose and care plan is effectively managing that patient's condition. That would need to be documented. Okay, let's get the next question loaded. All right, our next question is, which of the following practitioners are not eligible to bill for CCM services? And you can select all that apply. Is it A, clinical psychologist, B, nurse practitioners, C, dentist, or D, physician assistants? All right, if you answered A and C, clinical psychologists and dentists, you got that one right. This goes back to one of those top denials with claims denying for services not covered when performed by this provider. We usually see CCM billed by primary care practitioners, though others are able to bill them, including nurse practitioners and physician assistants. But CCM may not be billed by limited license practitioners, such as clinical psychologists or dentists, as CMS tells us these services are not within the scope of their practice. For RHC's billing chronic care management, we did have a question asking if the rural health G code for CCM has been eliminated. And if that question was regarding code G0511, yes, this was a general care management code, which included services such as chronic care management, principal care management, and so on. CMS phased out this code, so starting September 30th of last year, RHCs and FQHCs must use the individual codes for care management rather than G0511. That is no longer a valid code for Medicare. All right, we had another pre-submitted question asking if there have been any significant changes to CCM in the last couple of years. Other than this change in billing for RHCs and FQHCs, the only other significant change has been the rollout of Advanced Primary Care Management, or APCM services. APCM services combine several elements of existing care management services, such as chronic care management, transitional care management, and principal care management. And actually, Leanne and I will be doing another two-part series specifically on APCM at the end of July, and registration is now available out on our live events page. So let's move on to our next question. We have just a few left. All right. Next up, when is a new patient consent required? Is it A, monthly, B, if the patient changes billing practitioners, C, annually, or D, weekly? All right, the answer for this one is B, only if the patient changes billing practitioners. You do not need to obtain a new patient consent on a recurring basis, such as monthly or annually. We had a question asking if new patient consent is required if the billing practitioner changes, but within the same group. And the answer to that is yes. Regardless of group, a new billing practitioner would be the new practitioner overseeing the care plan, and new consent would be needed. It would be essentially starting over. The new practitioner would receive consent and develop and oversee their own care plan. Another question we had regarding consent was, does the patient need to be seen first by the new provider and then signing the consent, or is it okay to get the consent before the patient sees the new provider? And the answer to that is that chronic care management should start with an explanation to the patient before obtaining consent. So in a situation with a new provider, the patient would provide consent during or after the initiating visit once CCM has been explained. Consent should not be obtained before the provider has had the opportunity to discuss CCM with the patient. All right, next question. All right, for this question, the billing practitioner does not need to discuss CCM with the patient during the initiating visit. True or false? All right, you all got those answers in pretty fast. The answer for this one here is false. The initiating visit is required for new patients or patients not seen within the last year. And it can be done again during an E&M visit, annual wellness visit, initial preventive physical exam, or even during the face-to-face visit for TCM services. But it's not considered an initiating visit if CCM is not discussed. All right. One moment while I get the next question launched. There we go. All right, this question is, which of the following may not be billed in the same calendar month as CCM? And you can select all that apply. Is it A, E&M services, B, complex CCM, C, advanced primary care management or APCM, or D, annual wellness visits? All right, the answer to this one is B and C, complex CCM and APCM. You won't bill complex CCM and non-complex CCM in the same calendar month. It's one or the other. We did have a question about avoiding bundling denials. For advanced primary care management, or APCM, this is a bundled service which includes CCM, so you wouldn't bill both CCM and APCM in the same calendar month. For the other answer choices here, E&M services and annual wellness visits may be billed in the same calendar month. Just keep in mind, again, that time should not be counted twice. Meaning, for example, if you're billing for an E&M visit, you cannot also count the time spent on that E&M visit for your chronic care management service. They both can be billed in the same month, though. All right, our last question. Let's see if I can get this one to launch. There we go. All right, for the last question. Which of the following are true for the comprehensive care plan? And you can select all that apply from these options. Is it A, focuses on managing chronic conditions? B, may include expected outcome and prognosis? C, must be provided to patients? Or D, optional for CCM? All right, I know a few of you may still be thinking about it, but I'll go ahead and wrap up this one. The answer for this one is A, B, and C. CCM services must include a comprehensive care plan that focuses on managing chronic conditions. That MLN booklet on CCM gives some examples of what might be included in the care plan, such as expected outcome and prognosis, measurable treatment goals, and symptom management, just to name a few. The care plan must be provided to the patient either electronically or in paper form if that's their preference. We had a few additional pre-submitted questions I do want to address quickly before we wrap up. First, who creates the initial care plan? Well, the care plan must be created by the billing practitioner. The clinical staff may provide input, but ultimately the care plan is created by the practitioner. Then the next question asked, if the care plan is created by the clinical staff, does it need the provider's signature or oversight? Well, clinical staff can provide CCM services following the billing practitioner's care plan under the Incident to General Supervision Guidelines. So Incident to guidelines require that the physician initiates the course of treatment and provides subsequent services to reflect their active participation in the course of treatment. And what this means for CCM is that the practitioner is responsible for oversight and continued involvement in that patient's care. All right. Well, out of respect for everyone's time, we're not going to get to chat questions, but we will send out an email to everyone who attended today if we have any unanswered questions in the chat. If you do think of any additional questions, you have 7 days from today to submit those, and you'll send those to our education mailbox And make sure to include the title of this webinar, which again is Roadside E&M Assistance Interactive CCM Activity Pit Stop, or you can just put CCM Activity Webinar again in the subject line. And that will make sure that those emails come to Leanne and I. Please keep in mind that we're not able to access any claims history, so you will want to contact customer service for any claims-related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete that one without reading it. That email contains your certificate of achievement. It will have your name and contact hours in case you need to turn that in for credit towards continuing education units. Now, if you do not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Also, be sure to add messenger@webex.com to your safe sender list so that any future messages will show up in your inbox. Also, if you joined by phone only today, you would not have received this email, as there's not a way for us to capture your email systematically from our attendance record. No need to worry though. If you did join by phone, you're able to email us with the phone number you join with to request that certificate of attendance. And Leanne will be adding that email address to the chat. All right, last thing I want to mention is please take a few minutes to complete the survey. You can tell us what you liked, what you'd like to see done in the future. You can suggest topics for future education. And you have a few different options to take the survey. One, you can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. The prompt will look like the picture we have shown here with a little yellow triangle. We included this image here on the top right of the slide so that you know this is safe. It's not malware or anything like that. For those that might be listening through our website or through YouTube, you will also have the same opportunity to provide feedback. You'll have a survey card at the end of the presentation, and there's also a link available in the description. All right, that concludes our webinar. On behalf of myself, Leanne, and all of our provider outreach and education team, we thank you for taking the time to join us. We very much appreciate your participation in our Q&A activity. We look forward to your survey feedback, and we hope to see you again at future events. Everyone have a great afternoon. You may now disconnect.